You're listening to Medscape's In Discussion series on Hidradenitis Suppurativa, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeanette Okoye. Dr. Okoye is professor and chair of dermatology at Howard University College of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jeanette Okoye. Welcome to the Medscape In Discussion podcast series on Hidradenitis Suppurativa. Today, we'll be discussing advanced therapies for difficult-to-treat HS with our guest, Dr. Stephen Cohen. Dr. Cohen serves as director of the Weill Cornell Dermatology Center for HS at Weill Cornell Medicine. Thank you for joining us today, Dr. Cohen, and welcome to the Medscape In Discussion podcast.
And thank you for having me, Dr. Okoye. I'm really glad to be here.
So let's start by you telling us a little bit about your HS story. What brought you to this subspecialty?
Yeah, that's a great question because the doctors as well as the patients have a journey that usually starts when they become engaged with HS in a serious way. And mine started in 2015. So I've been doing this for about 10 years. And I think like every dermatologist, it's very hard to take care of HS. And when I first started, it was a struggle. I mean, I didn't really know which medications to use and which order to use them in. And I didn't know how to evaluate the really wide range of HS morphologies and disease severity that I was seeing. In this journey, it required establishing a mechanism for determining what therapeutic options work best in the different patient presentations. And this is ongoing. It goes on till today. I think we're far more successful now because we have many more therapeutic options. Some of the therapeutic options which were just coming online back in 2015, I'm happy to say that we explored them and have helped develop more effective ways of using those modalities. And we've been fortunate enough that it's more on the radar screen of the dermatology and the scientific community. And we're the beneficiaries of new developments that are in the pipeline.
Yeah, and indeed, the landscape is totally different than it was 10 years ago to our patients' benefit. And speaking of which, we now have 3 FDA-approved biologics for HS, plus, many of the off-label options we use. So in your opinion, is there still a role for antibiotics in the management of HS?
Well, antibiotics is a controversial subject. The short answer is yes, absolutely. When a patient comes to the office, they could be on biologics, they could be on hormone therapy, but if they are draining and they have culture positive exudate or drainage from wounds or abscesses that is not treated with an antibiotic, you can be almost absolutely positive that the efficacy of any remedies that you're using is going to be limited, at least in my experience. So we culture all patients every visit. If they have exudate, we treat accordingly. Now we have a number of different antimicrobial algorithms that we do use, and we use them in different settings. But we will use single, double, and triple antibiotic approaches. But we use the antibiotics in 3 different ways. We use topical, oral, and intravenous modalities. And it just depends on the severity of the disease and the response to the initial approach. We use exclusively minocycline. We don't use doxycycline. I think it penetrates tissues better. It's absorbed more effectively. We have pretty much rely on that for single therapy, usually an early stage disease. And then as we get disease above and below the waist, we get a different antimicrobial spectrum. So we're going to use different antibiotic regimens for that. I think you really need, fluoroquinolones when you're dealing with disease below the waist. And above the waist, you can use, clindamycin or rifampin. The cultures are so important because if we have a patient that has MRSA and we're not recognizing that, we're not going to get that patient better by giving them inappropriate antibiotic. So to answer your question, in the short, we definitely are very strong advocates of antibiotic therapy. And I might add to this that we combine antibiotic therapy with anti-hormonal therapy, anti-androgen therapy, and anti-inflammatory therapy. So they go together in patients with advanced disease.
Yeah.
And so early stage disease, we may limit our approach to one or two of these treatment arms. But for advanced disease, we find that the synergy between these three therapeutic approaches is critical.
Yeah, I mean, it makes sense that you're really going after three different pathogenic pathways in the disease, the microbes, the hormones, and then the inflammation. Makes sense to me. I have some more questions about the cultures and your antibiotic choices. So, have you noticed trends in the species that you tend to culture above the waist and below?
Below the waist, you're often dealing with coliforms, Klebsiella, Enterobacter, Enterococcus. Depending on whether or not you have more superficial or deep disease, you're going to have more anaerobic involvement or lesser anaerobic involvement. Above the waist, you don't see those sort of coliform organisms typically. You can, but that's much less common. You're more likely to see gram-positive organisms. You can see any organisms could be in any particular site. It just depends on how they're colonized. There is a difference. And like what I was saying about the cultures is that if I have a patient that has, we'll say Pseudomonas as an example, which is a very hard organism to treat, the only oral antibiotic we can use for Pseudomonas that's reasonably effective is a fluoroquinolone. Those patients are likely to get, either Cipro or Levaquin, whereas we tend to be very specific in terms of what we're growing. We're looking at our sensitivities, drafting our treatment regimen based on that. You started off by saying, do you even use antibiotics? And I think the other component of that is, do you culture? If you don't culture, you might not think antibiotics are important, but when you see the kind of organisms that you get and the sensitivity patterns, you become much more highly motivated to use appropriate antibiotics.
This is tough to ask because it depends on the patient and the culture, I realize. But what's your favorite double antibiotic regimen? And then same question for the triple antibiotic options.
No, that's a really good question because, we're in this kind of like weird universe where people don't really understand antibiotics, particularly. It's very difficult to understand how they work. What I'm going to say is that I have developed my antibiotic preferences on evidence-based medicine. It's not like I just decided, I would have some favorites and I would just try them. I've read the literature, and when the French in particular introduced Levaquin, rifampin, metronidazole, they introduced topical therapy with chlorhexidine and clindamycin. I started to rely on that because there was some evidence-based medicine that showed that it worked. To answer your question specifically about my favorites, for early stage disease, I do use minocycline pretty exclusively. So what would early stage disease be? Well, people have tender nodules or they have recurrent disease that's monthly or every other month. And so I might start with that and see if sometimes I can just suppress the disease with a few months of therapy. And I'm usually using hormonal therapy at the same time, whether it's a male or a female. And a lot of times I can stop the antibiotic approach when I have early stage disease and just use the anti-androgen therapy. But when people have a lot of disease, like say both axilla or inframammary involvement or abdominal fold involvement, I'm much more likely to reach for dual antibiotics. So that would be clindamycin and rifampin. When there's a lot of disease below the waist, or there are numerous anatomic areas that would include the suprapubic skin, the inguinal skin, the labial, the scrotal, the perineum, the buttocks, I'm going to use triple antibiotics. And those triple antibiotics would consist of Levaquin, rifampin, and metronidazole.
Now, not to get too in the weeds here, but this is my opportunity to pick your brain, Dr. Cohen. So you mentioned clindamycin and rifampin. I remember Dr. Rivuz from, he was French, taking care of HS when no one else was really looking at HS, and he had most of the papers and the textbooks. And he would use 600 milligrams of clindamycin 3 times a day, which is double or triple what we tend to use. What's your usual dosing regimen?
I use 300 milligrams twice a day. I like clindamycin and rifampin because they're both 300 milligrams. They take the 2 pills in the morning and the 2 pills in the evening. I usually tell them that, rifampin is going to turn their urine and all their secretions actually a little orange or red. It's not blood. It's just a dye in the antibiotic, and not to be alarmed about that.
All right. So it's good to know that at that lower dose than the European guidelines, you're still getting efficacy. Now, our colleagues in infectious diseases are sometimes quite concerned about our use of antibiotics, especially since we use relatively long courses. And there's definitely lots of conversations about using clindamycin and rifampin together, and the fact that because of these CYP interactions, eventually you are on rifampin alone because the rifampin sort of induces the enzymes that break clindamycin down. So, what are your thoughts on that? Are you worried about that at all?
The reason this combination was developed is because clindamycin as a monotherapy has a high risk of colitis, a pseudomembranous colitis, and that is a non-starter for using that drug. So it became a challenge to have this patient population that might get a good response to clindamycin, but then they'd have to go off the drug because they got colitis. The rifampin has its own problem. If you try and use rifampin alone, you're going to get a high frequency of drug-resistant staph. And so that's not a good thing. When you combine these two drugs together, clindamycin is very effective at removing the drug-resistant staph. The rifampin is very effective at reducing the tendency to colitis. You have these two drugs working like in synergy. They protect each other. And so I never get patients with colitis ever. And I don't get nearly the degree of drug resistance with clindamycin and rifampin as if I tried to use them separately. Of course, I never tell patients to do that, but sometimes patients come in and they say, "Oh, I ran out of clindamycin. I've just been using the rifampin by itself." They're flaring and they have, some resistant organism. And that's the only way I really know about that. But I really work hard to avoid that.
Just my final question here about antibiotics before we move on. You mentioned IV antibiotics. I assume you're referring to IV ertapenem. Can you tell me a little bit about your experience with that option?
Okay. Well, I'm going to tell you about IV drugs rather than just IV ertapenem. But ertapenem is a drug which I like to think that, although we didn't develop it, again, that's another drug. The French were very much in the lead for developing ertapenem therapy, but they had a very different treatment algorithm that we ultimately wound up using. They were using IV ertapenem for 6 weeks. And then Joan Lambert was putting the patients on triple antibiotic therapy, levaquin, rifampin, and metronidazole. And he reported phenomenal results. And I started out doing that, and I didn't get very good results post-treatment. I got great results initially. It's just an amazing drug. It's just an incredible drug. But if you stop in 6 weeks and the patients get their disease back in a few weeks or a month, it's like, wow, they spent 6 weeks with a midline or a PICC line in their arm, and then they wind up with the disease back again. Although I used to sell that in the beginning, that they would be getting a little holiday from their HS. And I decided at some point that maybe we should extend the treatment interval. And so we started treating patients for 8 weeks, and then 10 weeks, and then 12 weeks. The paper that I reported in the JAMA Derm a couple of years ago was 98 patients that were treated for 12 weeks. And the data itself is remarkable in terms of efficacy. But actually, I have extended the treatment interval to 16 weeks. So I'm keeping patients on the drug for 16 weeks. Now, I said IV antibiotics rather than ertapenem exclusively because ertapenem is a carbapenem antibiotic class drug. If you have an organism that produces carbapenemase enzymes, they inactivate the carbapenem antibiotic. So ertapenem can be inactivated, for example, by Pseudomonas. which is a big problem. If you start getting Pseudomonas colonization, you got to do something to fix that. Ertapenem is not great for MRSA. You might want to have patients on linezolid even while they're on ertapenem. What I have done at a pretty significant investment for the patient is when I have patients that they have intractable Pseudomonas colonization, I switch their antibiotics out and I put them on a drug that's a combination drug called ceftazidime avibactam. I think soon we'll probably be reporting some of this data. The reason that we don't like the drug is not because of its efficacy. It's a really great drug. It knocks out the Pseudomonas almost immediately. However, it's like ertapenem is a 1 infusion a day drug. So it's 40 minutes. It's pretty easy for the patients to administer as a routine. But when you're talking about a 3-time-a-day drug, for example, if a patient gets admitted to the hospital with HS, they're going to put them on, Zosyn and vancomycin. And you say, well, why don't we use Zosyn and vancomycin? And the reason we don't is because it's 3 times a day, and it's like, it's like an hour and a half infusion. And the ceftazidime avibactam is also, it's almost 2 hours. So you got 6 hours a day that people are using these infusions. So it depends on how sick they are, and it depends on whether they're working or they're not working. I have a whole bunch of patients who are on this drug. It's because it's so effective, and they really appreciate not having active disease. But it's a big investment. So we've actually also are using a third IV antibiotic in the cycling class, and that's called omadacycline. Omadacycline is actually an oral drug, so you can give it orally, but I find that it's not all that effective. But it's a once-a-day drug. You can give it IV, and if you already have a PICC line in, you can try this. It's also a really effective drug in the right patient. Most of the patients get ertapenem, and when they get to the end of their 16 weeks, they're in remission, and we transition them back to oral antibiotics. You must use oral antibiotics when you finish. You can be, as we were initially, we were overconfident. We saw how great the patients were doing, and we said, gee, they won't need antibiotics anymore. I tell them from the very first minute they're going to start on ertapenem, you will be on antibiotics as soon as you're finished with the ertapenem until we have an extended period of remission without any active disease. We might reduce the antibiotic spectrum, the number of drugs we're giving you, or we may be able to transition you off of antibiotics. But I always want people to know that they have to go back on antibiotics once the ertapenem is complete. And you ask me about the journey associated with taking care of patients with this disease, and ertapenem is one of the more complex therapies to use because you have to have a relationship with interventional radiology. You have to be able to put a PICC line in. You have to have a relationship with a home infusion service because the patient's going to do these infusions. For the most part, they do them at home. And so they have to go in and they have to service the line, clean up the dressings every month, make sure that the line is intact. And so just learning how to do that is a little complicated. Once you get it down, it's okay, but it's tough. I think that if our colleagues were able to get more training in getting patients started on this drug, they wouldn't have to be flummoxed, if you know that word, just shut down by our infectious disease colleagues who they're involved in antibiotic stewardship, and they have this very appropriate concern about antibiotic multi-drug resistance and having patients that where they won't be able to use carbapenem antibiotics. I get that. But we're dealing with patients that don't have a life.
Yeah.
And it's like taking a cancer patient and saying, well, we're not going to use a certain cancer therapy because it's too toxic or it's too valuable for another cancer and we won't use it for this one. I mean, if you have a life-threatening disease, and I do think HS is life-threatening in its advanced forms, many of our patients, are depressed and suicidal, and I don't need to tell you that. We're looking at risk-benefit. Our patients need ertapenem when they have advanced disease. We just cannot ignore what they're going through. At Weill Cornell, where I'm at right now, I have a very good relationship with ID. And when my patients get admitted and they're on ertapenem, they continue their ertapenem while they're in the hospital. But I didn't have that at my previous institution. They were just very rigid, and they wouldn't teach me how to do it, and they wouldn't sanction it. I had to learn on my own, which I did. it's really worthwhile if you're taking care of a lot of HS patients to become familiar with how to use that therapy.
Yeah, and then, to your point, it's worth the risk benefit is worth the legwork and the relationship building and so on that we have to do to put these things in
Absolutely.
place. So I agree with you. Now, Dr. Cohen, I have many more questions, but we have a limited amount of time. Do you have any parting words, anything you'd like us to have discussed?
I will give you some parting words because I really want to emphasize or leave you with the importance of synergy between therapeutic classes. I really think it's incredibly important to factor anti-androgen therapy into treatment. I can't give you the mechanism, but we know that this disease begins at puberty, and that begins when androgens become active, whether you're a male or a female. And we have good anti-androgen therapy that's not particularly toxic. For women, we can use spironolactone. We can use finasteride in women also. Birth control pills are really great, and they can be very low estrogen birth control pills. I really avoid progesterone. And for men, we can give them finasteride as a monotherapy. But I emphasize the importance for very low risk of using the secondary class of androgens and then anti-inflammatory therapy. It's very important. You mentioned right in the beginning about how, well, now we have 3 drugs that are approved for HS, adalimumab, secukinumab, and bimekizumab, and they are very important drugs. But I also want to leave you with a caveat that those patients with a high BMI tend to have a much reduced efficacy with fixed dose treatments. Having an anti-inflammatory approach, giving patients weight-based therapy, whether it's infliximab or golimumab or whatever weight-based therapy that you're doing, is really important. And we did not discuss other things that I want to leave as kind of something to remember after this is over, which is one is surgery, deroofing, and treating abscesses with surgical approaches is incredibly important and incredibly effective. And we did not mention that in the treatment algorithm. The treatment algorithm is expanding, and so it puts a lot of pressure on those of us who are uh, doing HS as a specialty, but we have a lot to offer our patients. I emphasize the need for synergy between drugs and early treatment. The earlier you can get a patient on treatment, the better. And to try and think more about surgery when patients are having structural problems with sinus tracts or tunnels, or they just have foci that will not be suppressed with conventional medical approaches.
You mentioned in passing when you were talking about the anti-androgen therapy, and I love that phrase versus hormonal therapy because it's much more specific. You mentioned that you avoid progesterone. I think this is a really important point to leave our listeners with. Can you end with that?
Sure. A lot of the patients, if they're coming in from a GYN setting, the GYN physicians are doing 2 things. One is they like progesterone contraceptives because they're very effective and they may even be a little bit better tolerated. They tend to have more androgenic effects. So if you're going to take oral contraceptive patches or you're going to use an IUD that's got a hormonal IUD, these are almost pure progesterone and they can aggravate HS. And so if you wanted a final parting word, try and avoid progesterone contraceptive measures. We tend to use low estrogen, really low estrogen, the lowest you can use, and it's very effective. We're just really trying to kind of swamp the androgens that are around. And of course, as you know, a lot of the GYNs now are using continuous therapy to suppress the menstrual cycle as a way of administering a birth control mechanism that makes the women a little more regular in terms of, or less regular, but less affected by menstrual irregularities. And that poses a problem in of itself because they're getting progesterone 1 month long. And it makes it really hard for us. I would just try and wean patients off of that if you can.
Well, the good news is in our next couple of episodes, we're going to be speaking to a surgeon and we'll be speaking to an OBGYN. So we're going to delve even deeper into these topics.
That's great.
This was amazing, Dr. Cohen. There were so many other topics I wanted to cover, but I love the fact that we spent 30 minutes talking about antibiotics because I think that they are becoming a lost art in dermatology. And so I
Indeed.
appreciate all of your wisdom.
Oh, thank you. I appreciate it. Thank you so much for having me. I really have enjoyed talking to you.
Today, we've talked to Dr. Cohen about the use of advanced therapies, including advanced approaches to using antibiotics in the management of HS. Thank you for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on HS. I'm Dr. Jeanette Okoye for the Medscape in Discussion podcast.
Thanks for listening to Medscape's In Discussion Hidradenitis Suppurativa podcast series with our host, Dr. Jeanette Okoye. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on hidradenitis suppurativa.